Good morning, everyone. First, we have a left-hand dominant 51-year-old female. She's had struck with this right proximal humerus fracture. Of note, this patient is had a stroke several years ago. She's with subsequent right-sided dysfunction, including, and she does not use the right upper extremity for activities of daily living. We opted for non-operative management for this patient in a sling. Next, we have a right-hand down.
Is that an old clavicle fracture?
That's an old clavicle fracture. We have a right-hand dominant 15-year-old male. He's arm wrestling, lost. He has this left femoral shaft fracture. He's placed into a coaptation splint. He had a radial nerve intact before and after the splinting. Next, we have a right-hand dominant 49-year-old female. So this was MVC with this left ulnar shaft fracture. She was close reduced, placed into a sugar tongue splint. She'll follow up in the office. Next is a 24-year-old female. She was skiing when she sustained this. She fell and she sustained this right tibial plateau, very minimally depressed lateral tibial plateau fracture. She'll follow up as an outpatient in Colorado, where she lives. Thank you, guys.
She came here from Colorado to go skiing.
Yeah, exactly.
She needs
She
a
was
psychiatric evaluation before she leaves.
Yeah.
Morning. First patient's an 84-year-old male. Status post-fall with a left periprosthetic distal femur fracture. Underwent a distal femur ORIF with lock complete.
What's going on with that patella?
Yeah, so history of a patella fracture 10 years ago that was treated operatively here in this institution. He had like one of these wires was actually pretty prominent. So we went ahead and just did a little removal, a partial removal of hardware. But yeah. Next is an 85-year-old female, status post fall with a right hip intertrochanteric fracture. Underwent a right hip intramedullary nail. Next is a 50-year-old male, status post bicyclist struck with a right lateral tibial plateau fracture. Underwent a CT. And we'll manage this non-operatively for now. Close follow-up. Next is a 36-year-old male, status post fall with a left distal radius fracture. Slip and fall at work on ice. Close reduced, sugar tongue splint. Next is a 37-year-old female, got on her son's hoverboard and fell off. She has a cuboid fracture. It's non-displaced. CT of her foot here. They were concerned for this frank, so they got this cuboid fracture.
What could you do in the office if you're concerned about a Liz Frank?
Yeah, you can do a weight-bearing film,
Mm-hmm.
which we also did, and it was also negative.
Cool.
I should have included that. 91-year-old female, status post fall with the right proximal humerus fracture, non-weight bearing with a sling.
First patient's a 39-year-old male, was a pedestrian struck crossing the border 3 weeks ago, the right AC separation. He was neurovascular intact. We're going to have him follow up as an outpatient in clinic and plan for reconstruction if he follows up. Is an 88-year-old female who's floridly demented.
Why reconstruction? What type is it?
It's a type 5.
What makes it a type 5?
It's like almost 200% displaced.
Is it sticking through the fascia posteriorly?
It's mostly reducible, so I don't think so.
So how is that a type 5?
Type 5, over 100% displaced.
I'll double check that, but to me, it's from what I remember, type 5 is buttonholing through the fascia. And is it reducible?
Type 3 is usually reducible. Type 5 is not. So this is reducible, Todd, or not?
It didn't go all the way down. It went most of the way down.
That's what she. So why is it not reducing? What's pulling on that bone?
Sternocleidomastoid.
Yeah, and the trapezius. So if it's buttonholed through the fascia, the deformity will either stay the same or accentuate when the patient shrugs. So usually a type 5, I agree, is going to be symptomatic. That's a problem. It's a type 3. Most of the time, you tell them to live with it, they'll live with it, unless they're an athlete or someone who's doing heavy duty overhead lifting.
Mostly just running away from control. There's an 88-year-old.
So Todd, if you were going to fix this, what are 3 or 4 different ways to fix this, and which one would you guys choose?
So there's a bunch of ways. You can do a hook plate. You could do an endo button. You could do a ligament reconstruction with Weaver Dunn. You could use allograft or autograft. I think I would lean towards endo button, but I've actually never done one of these cases. Do you guys have preferences?
Well, what's injured here? What ligaments are injured?
The conoid and trapezoid, and the AC ligaments. And the
So I've done it both ways when you feel like it's symptomatic enough to fix, and I would agree with things that have already been said. And the thing isn't like tenting the skin, and you don't have reasonable reason for the individual patient for their needs. The 3s really do fine left alone. I mean, don't let the little old lady who's playing pickleball talk you into fixing a type 3. Not that it happens to little old ladies, but to fix them, I grew up with the modified Weaver Dunn. It's not the greatest operation, but it's a good operation. It never gets it all the way down and staying down, but at least those people, again, are made from 5s essentially into 3s, and they do well. The endo button technique is pretty cool. I like it. There are some problems. Just using a Weber bolt is the same kind of a problem. You're making a hole in the clavicle and in the coracoid process, and you can get pathologic fractures. I like to do it with arthroscopic, assistance so that you can see the coracoid, but you need a 70-degree scope to do that, which is not a big deal. Most places have that. It's just a little bit more challenging, and it needs to be done acutely. You can't. My feelings are that you can't do an AC separation that's chronic with a endo button arthroscopically. That's one you're going to need to open to fix. And you have to sort of fillet out the fascia and clean out the area to be able to put the clavicle back underneath the fascia and then repair it back over top, which I would argue is probably the most important part of the operation. Is not, regardless of how you do it, is making sure that you have the fascia on top and it's going to help hold it down.
Yeah, I don't think there's any sort of real advantage to getting to these early. Would certainly totally exhaust non-operative treatment here, and really make somebody be miserable before they come back, because either way you need to do, there's no minimally invasive way to properly fix this. So there's some degree of ligament procedure you're gonna do, whether it's coracoid augmentation or a hook plate, if that's really what you want to do. So definitely would not talk this guy into early surgery.
I disagree a little bit. I disagree a little bit there. If you fix it early, if you got to fix one early, it's clearly a type 5. You still have ligaments there. So fixing it with however you choose, but say the button technique, you still have tissue there. So you may not need to supplement with cadaver graft. If it's chronic, you definitely need tissue.
Yeah, what I mean is in a type 3, not in the type 5.
Okay.
Yeah, and I would just say that there is some literature to say that type 5s can do okay non-operatively depending on their demand. So, that's where you got to get to know your patient. Todd's not really presenting a picture of somebody who we want to rush to surgery, but one other point, Todd, just to remind you, is like, that the endo button is the name of a company. So the technique, we want to say is more of a cortical button, so that you're kind of learning the technique and not the company's name for that device.
Gotcha.
Clearly, you're not sponsored by the endo button.
I thought it was the internal brace.
Different company.
Next one is an 88-year-old female, floridly demented, fell in nursing home with a C2 lateral mass and transverse foramen fracture. She got CTA that was negative for vascular injury. She was placed into an Aspen collar, which she readily disposed of, and she went back to her nursing home. This is a 52-year-old male who sustained a fall and was found to have a pathologic right acetabulum and iliac wing fracture. He had no pain prior to his fall, but upon imaging, you see this large destructive lesion in the acetabulum, particularly the posterior column that extends into the anterior column as well. He had no known cancer history and was found on this scan to have a lung mass and has since been confirmed to have lung cancer. Is also metastatic to the brain. He usually had those lesions resected. We got an MRI to better evaluate this, showing just how extensive this is. This guy is pretty active. He's actually a hairdresser. So after the neurosurgery team is done with him here, we're recommending he be transferred to Newark for reconstruction. There's a 69-year-old male who fell getting up from his recliner and sustained this left hip periprosthetic greater choke fracture. You'll note he also has polywear, and they got a CT scan that shows a large pseudotumor. He had been having pain here for over 9 months prior to his fall, intermittently, but then acutely worsened from the fall. His implant also looks pretty loose, the femoral stem. So he's pretty sick. He's a COPD on 6 liters of home oxygen, peripheral vascular disease, has coronary stents. So he would need a pretty significant medical optimization if we were going to consider revising this, but I think you'd have to switch out the poly and switch out the femoral stem.
How old is the prosthesis?
It's from 2000.
Have you ruled out infection?
Yeah, all of his inflammatory labs were negative. So when we see him as an outpatient, we want to get an MRI with the Mars sequencing, but they don't do that here. is a 55-year-old female. Status post fall with a right ankle trimal fracture. She was initially closed reduced, replaced into a short AO splint, and then followed up as an outpatient for ORIF. Of note, she has poorly controlled diabetes, so we want to add extra fixation.
Is a 57-year-old male, slip and fall on ice, has a right distal radius fracture. Was closed reduced, put in a sugar tongue splint, follow up outpatient. So 55-year-old female, another slip and fall on ice, has a left distal radius fracture, is also closed reduced, put in a sugar tongue splint, and we'll follow up. This is an 82-year-old female, another slip and fall, had an L1 compression fracture. These are just representative CT cuts. She was neurovascularly intact, intact, just a little bit of tenderness palpation to her lumbar spine. She went home to follow up in the office, no brace for her. This is an 84-year-old male, another slip and fall on ice, had a right acetabulum fracture, no antecedent pain, very active individual. Here are representative CT cuts. There wasn't much articular step off. Everything was pretty congruent. So he is going to be managed non-operatively, toe touch weight bearing on that side.
Morning. The first patient is 75-year-old female, status was fall with left ankle fracture. Patient was taken to the OR for left ankle open reduction and internal fixation. Next patient is 57-year-old female, status was fall with right ankle fracture. Patient was taken to the OR for right ankle open reduction and internal fixation. Next patient, 72-year-old male, status was fall with left hip IT fracture. He was taken to the OR for left hip IM nail. Next patient is 60-year-old female, status was fall with right ankle fracture. Patient was taken to the OR for right ankle ORIF. Next patient is 21-year-old female, status was MVC, who was diagnosed with the left acetabulum posterior wall fracture and right talus fracture. A patient was taken to the OR for right talus ORIF, and the left hip was examined under anesthesia and was found out to be stable. Thank you.
Sorry, you said there was a CT of that talus?
Yes, we got CT of the talus. So it's a talar neck with a little comminution on the lateral side, and there is lateral process fracture.
Yeah, so on that top right where you see the lateral of the foot, and now go to your fluoros or post-op films. Because it looks like the screws that are holding the neck are either in the fracture or a millimeter or two before the fracture. So I'm not sure.
On the lateral side?
No, not lateral side. Look at the middle view, the lateral. You can see kind of where the fracture is there.
If you look at the fluoro AP of the foot, those screws go from medial to lateral. So they're on the medial neck where the fracture was the thickest, basically. It went from medial, like sort of posterior in the talus, to anterior lateral. So they actually are, we're actually where they need to be. It just looks that way because it's deceptive, because they're actually very medial.
Andrew, which position did you have the hip in to test the stability? And which view did you get?
Yeah, so the patient was supine. And we start with the AP of the pelvis X-ray with the leg in extension, and then we flex to 90 degrees, and we apply axial load. And then we did the same procedure with the slightly abduction and internal rotations, and we flex to 90. And it was a lot of force, axial force, and open.
And which view? Which view do you see the posterior wall in? And so which position did you have?
It's like the obturator view, but we only saved this one view for documentation, so I didn't have another views on the floor. So. But we look at
fine.
that.
You just have to know which view to look at for the displacement of the wall, which is the obturator.
Jay, did you consider putting a plate on that talus?
It was non-displaced, and we got good fixations with the screws. So we were prepared for putting the plate, but the medial side was not comminuted. The comminution was on the lateral side. So, and most likely this fracture is going to varus. So if there is anything, we should put the plate on the medial side. But medial side was.
You got good compression on the medial side.
So we got a little compression. We didn't go crazy with the compression. So we didn't want to put it into varus, but we got some compression on the screws.
It was really a head fracture. It's not a neck fracture. It went through the head. So it's basically just a fracture of the anterior sort of left corner of the medial side of the tail of the head. So there's really nowhere to put a plate. It was all articular.
Got it.
Thank you.
All right, good morning. We have a few from St. Peter's to present this morning. First patient is a 55-year-old male presenting after a fall with a right humeral shaft fracture. Patient was neurovascularly intact, radial nerve was intact. Placed in a coaptation splint, radial nerve was intact post production as well. Next patient is a 44-year-old female, status post fall, a right distal radius fracture. Patient was neurovascularly intact, closed reduced, placed in a sugar tongue splint. Next patient's a 32-year-old female.
So Dan, let me go back to first go back to the humerus fracture, and I imagine you're going to try to treat that patient non-operatively. You're going to follow him in the office and put him in a coaptation splint or a coaptation brace. What would be an indication that that patient might need surgery, and at what time point would you consider intervention?
Yeah, so I mean, in the initial presentation period, I mean, if there's any vascular injury or if there's an open injury that would warrant immediate, taking the patient to the OR. Later on, usually it's at around 6 weeks. If there's still gross motion at the fracture site, then you consider that there may be some healing, potential issues with healing of the fracture. At that point, you can consider having discussions about surgical fixation. But these can take quite a while to heal. There's some literature showing that it can take upwards of 6 months, if not longer than that, to fully heal. So I think it's reasonable to continue watchful waiting as long as there's some sort of evidence of healing.
Yeah, I think that's a good point. I mean, I think you got to wait at least 6 weeks before, and possibly even longer, before you alter your treatment plan here.
Yep. Thank you. Next patient's a 32-year-old female. She suffered a direct blow, direct blunt trauma to her left wrist, left distal ulnar shaft fracture. Patient was closed reduced, neurovascular intact, closed reduced, placed in a sugar tongue splint. Next patient's a 89-year-old male presenting after ground level fall with this right hip intertrochanteric fracture. Patient was medically optimized and taken to the operating room for a right hip intramedullary nail. Next patient's a 70-year-old male, status post slip and fall on the ice with the left ankle bimal equivalent fracture. Patient was neurovascularly intact, closed reduced, placed in a short AO splint, and will follow up for outpatient surgical planning. Next patient is a 60-year-old male presenting after an MVC with a left C5 transverse foramen fracture. Also had a left vertebral artery dissection at the level of C6 that was evaluated by vascular surgery, no acute intervention. Patient did present with this like cervical central cord syndrome with significant neurological injury, diminished sensation throughout, and no purposeful motor in the upper or lower extremities. MRI was obtained, showing severe canal stenosis from C3 to 7 and disruption of the disc space anteriorly at C4, 5, and C6, 7 with disruption of the anterior longitudinal ligament. Patient was taken to the operating room for C4, 5, C5, 6 anterior cervical discectomy and fusion, posteriorly a C3 to 7 laminectomy and posterior fusion. Thank you.
Oh, little Dan, someday they'll let you leave the Shire of St. Peter's.
Oh my God.
Morning. This is a case that was previously presented, a 29-year-old male who was a drunk driver in MVC with a right open trimal ankle fracture. CAT scan was initially obtained due to significant comminution. He was provisionally taken for an IND and an X-fix. There was a 5 centimeter wound over the medial side. And 2 weeks later, we took him for a right ankle removal of X-fix. The wound was healed, so we performed a ORIF.
So I manipulated that guy's X-fix at one point in time. And it was, even after I screwed around with it for 15 or 20 minutes, still posteriorly subluxated. What do you think you could have done differently to make that better? And you may not have been the one that put the external fixator on, but.
Yeah, no, I didn't put the X-fix on, but I don't know, possibly adding a metatarsal pin to possibly pull it forward a little bit more and have some more stability, but I'm not totally sure why. It could have been due to the comminution posteriorly, but I'm not really sure why that would prevent
So
it.
for me, it's weird. I think sometimes if the pin is, a single pin and it's, more anterior, that allows the foot to go in to, a plantar flex position, which sometimes can push that posterior segment off the back. And then you just have to sort of dorsiflex them, or don't over dorsiflex them because it can have a similar effect. But there was just, maybe I should have put another pin in. I knew he was going to be going back to that's part of the reason you put an X-fix on, right? I had strong expectations that he was going to be going back to the operating room for, a more formal fixation. So I didn't get that worked up about it. But those patients that are those more complicated traumas where you're not sure when they're going to get back to the operating room, you don't want to leave the operating room with an X-fix on that isn't right where you want it. You know what I mean? So it's just, it's frustrating. And it's not the first time I've been in that position, but I honestly don't think I have any good pearls. This is really a Carlos or a Serge question. If you're, if there's something else that you can do, whether it's supplemental fixation or throw a K-wire across it. Do you guys have any recommendations for that ankle that just will not stay reduced even in an X-fix?
Tim, the first thing I would put in 2 pins in the calc, and you have much better ability to pull it anteriorly. You're exactly right. It rotates on a single pin. So that's the one right off the bat, put 2 pins and couple them together through the calc. You don't, in the metatarsal pin doesn't really do much.
I usually go with the cuneiform pin. It's a little closer and it's in a more stable area, assuming you can put it there. It's creating a kind of multi-planar stability. This way it doesn't translate posterior. This one specifically, the the reason it kept coming on the back, and you see the two plates on the posterior malleolus, because there was a large articular fragment and a smaller fragment, but it had all of the ligament attachment to it, the PITFL. So through the ligament, there was no ligamented taxis. The posterior mal, big articular piece was out the back, and the ligaments weren't really holding it. So it kind of, I see why it wants to keep sliding out and then not really staying in place.
Hey, Tim, you made my day. You took that back to your thinking you could do better, but you couldn't.
Once.
All right, good morning, everybody. Oops. First patient is an 89-year-old female, status post-fall, who had this right femoral neck fracture. She was medically optimized and taken the following day for a right hip hemiarthroplasty. Next patient is an 80-year-old female who fell and had this left hip intertroch fracture, who was taken for a left hip intramedullary nail. Next patient is a 45-year-old gentleman who was ice skating and fell onto his wrist, sustaining the right distal radius fracture, who was closed reduced and placed into a sugar tongue splint. Next patient is a 71-year-old gentleman who had his hand crushed by a snowblower and sustained this left hand index finger P2 and 3 fractures, as well as a middle finger middle phalanx fracture. There were small, less than 1 centimeter lacerations on the distal pulp aspects of both of the index and middle fingers. So he was irrigated and given tetanus and antibiotic prophylaxis. He was splinted and buddy taped both of the digits. He had no rotational deformity on examination, and he was neurovascularly intact. Next patient is a 96-year-old female who had an unwitnessed presumed fall at a nursing facility. She is non-ambulatory with dementia and some cardiac comorbidities as well. She was grossly neurovascularly intact. She was actually moving her shoulder. The ED had attempted some close reduction unsuccessfully. I attempted a gentle close reduction with an intra-articular hematoma block, but was unsuccessful due to her comorbidities and her underlying dementia. We opted to leave it dislocated. Next patient is
I agree. I mean, you have no idea. You have no idea how long that's been out. I mean,
yeah,
axillary. Something looks funny there. So you could always get a CAT scan to show if there's any sort of chronicity there. But the worst thing you could do is, tear an axillary artery in the ER. So less is more here.
96-year-olds also don't move into the neighborhood, like suddenly. I'd be surprised if you couldn't find an old chest X-ray in the computer that wouldn't show you that was already there for a while. That never is a surprise to me.
Yeah, I did look in all of Univrad and Singo here to see if there were any old images. There are actually 0 images of her ever until this presentation, so I'm unable to prove that, but I wouldn't be surprised as well if this was chronic. So. This is a 78-year-old female who is nonverbal and non-ambulatory and non-responsive. She had a TBI essentially 8 years ago that left her non-functional. She has severe contractures of all her limbs. Her family was transferring her and heard a crack and brought her to the ED, where she was found to have this left distal femur fracture. She was neurovascularly intact, good ABIs and pulses in that extremity. She was placed into a very, very bulky knee immobilizer and placed on DVT prophylaxis with plans for non-operative treatment.
So I've seen it twice where that knee immobilizer digs into the leg down by the ankle. when the patient's in the nursing home, like a month later. So you really do have to continue to keep it very well padded if you're going to keep them in that brace, or perhaps remove the metal side slabs. It can be a disaster.
Yeah, I removed the metal like back bar. I kept the ones on the side, but she actually went home. She lives with her daughters, who I get, one of them is like some former nursing aide. So I talked to them pretty extensively about just like checking her skin all the time, essentially just to make sure that there were no signs of like pressure ulcers. But she would be, I mean, she obviously is not a good surgical candidate. So she's kind of left in the situation that she is.
Yeah.
Should be a surgical candidate when her femur erodes through the front of her thigh, but later. Hey, Anna, that one of the first patients you showed was a hemiarthroplasty.
Yes.
Do they make a big deal about those prostheses going in and a little bit of valgus still, or is that not an issue anymore?
I think I guess it's not as big of an issue. We prefer valgus instead of like varus. But we thought it was acceptable.
Good morning. First patient, 83-year-old female who presented with the greater troch fracture on the left side. However, her exam was concerning for inner troch extension. We got a MRI that did demonstrate inner troch extension of that fracture. So we took him to the operating room and did an intramedullary nail. Next patient is a 63-year-old female, status post fall, presented with right trimal ankle fracture that was closed. She was splinted and taken to the operating room for open reduction and internal fixation. Next patient's a 50-year-old female, status post fall, presented with the right trimal ankle fracture. Was reduced. Taken to the operating room for open reduction, internal fixation. Next female is a 58-year-old female who fell, had an open bimal equivalent ankle fracture, about 2 centimeter open in the medial side. She was given antibiotics, washed out in the ED and splinted, and then taken to the operating room for open reduction, internal fixation. Next patient is a 64-year-old male, status post fall, the right trimal equivalent ankle fracture. This was a closed injury. He was initially splinted. They got a CAT scan of the injury while he was unreduced in the ED. There is, a posterior mal fracture, but it does not involve a large portion of his articular surface. And there's combination on the fibula. He was taken for open reduction interfixation.
Can you get an idea for the posterior tib fib on a CAT scan, or is that not something that you can identify as an injury?
Sorry, what was the question, Dr. Lady?
Can you get an idea for that posterior tib fib ligament that they were talking about before on a CAT scan, or is that only something you'd be able to see on an MRI?
Well, knowing like kind of where it inserts, and it's kind of like fan-like insertion on the posterior tibia, you get an idea whether or not it's going to be competent or not. I think,
So how big does the piece have to be, and where does it have to be?
I don't know the exact numbers.
It could be a relatively small piece.
Yeah.
Because the ligament kind of cone is like triangular and cones down onto the posterior malleolus from the fibula. So the piece can be very small. That's why the articular size of the posterior malleolus is why it hasn't been proven to be predictive or determinant of what the outcomes are. It could be a small posterior malleolus, but the PITFL can be avulsed on that little small fragment. On this view, Dan, how did you do? You have Flora showing a perfect mortise? Because all I see is the fibula is not reduced correctly. Because there's no mortise view where the fibula lines up with the talus. It's all overlap.
I think.
How did you gauge your reduction of the fibula?
So we kind of looked at there's kind of like a posterior lateral cortex that was kind of intact or lined up. So we used that to kind of gauge that with the right length, alignment, and rotation. I understand how, like, there is that. There looks like anteriorly the fibula might be a little bit internally rotated there, but that's kind of what we used to kind of think that we had good length alignment rotation.
I suspect your fibula is anterior to where it should be, because there was a posterior malleolar fragment of this fracture, right?
Yeah.
So it, because the plate overlaps it, you can't tell where is the position, so you can't really tell if it's close to where it's supposed to be sitting. And that will give you an idea. If the posterior malleolus is flying out in the wind, that means the fibula is probably not in the right place either, because they're connected. But it's hard to, you can't tell in that lateral. It's just there's no mortise view that you have where the fibula is side by side with the talus instead overlaps it. Even the one on the left, there's some that looks like they're touching or overlapped, and your post-op lateral films, although here it looks normal, but the fibula is never supposed to be in the middle of the talus. Part of the fibula usually sits behind, at the level of the posterior malleolus, or even a little behind it.
Mm-hmm.
Although this guy has some like arthritic changes there, so that might be a little different for him.
Yeah, he's a very unhealthy person. Last patient is a 70-year-old male. Steps with fall. He had a proximal fibular fracture with the syndesmosis injury distally. He was close reduced, taken to the operating room for an open reduction and internal fixation.
What did you use to assess the position of the syndesmosis, the reduction of it?
So we made kind of this anterolateral incision to directly visualize it open.
And what are you looking for when you do that?
We're just making sure the fibula is sitting inside the incisura, and we make sure that there's no soft tissue kind of interposed.
Yeah, we usually look for where the talus, tibia, and fibula meet. That'll help you judge so the fibula is not too anterior, too posterior, and it's sitting in the incisura.
That's it from St. Peter's.
Funny looking dog.
Can you see my dog?
Actually, I shared the screen.
You take that back, James.